Good evening, ladies and gentlemen. Welcome to another recall class. I hope all of you are doing well. Let's just wait a couple of more minutes before everyone can join, and then we will start our session today. Good evening, Dr. Fatma. How are you? So we will be continuing the June recalls today, guys. And we have a bit of more questions today, so I'll be going a bit quicker than my normal recall session. But if I'm going a bit too fast, you guys need to vocalize that to me in the chat box. All right, guys, let's start our class today. Are you guys able to see the screen? All right, so we'll be continuing with the June recalls. This is our first question. And Immigrant man comes and tells you that in his country, secret police are after him and they want to kill him as they are worried that he would leak some information about the person who was involved in the killing of another person. What will you check in his collateral history? Immigration status, childhood psychiatric disorder, school performance, truth of what he is saying, family history of mood disorder. So majority of you are answering B and some of you are answering D. Let's go through this one by one. It's not our job as a doctor to ask about the immigration status. We know it's an immigrant man. Status of immigration is not our job. So, and in the collateral history, if there is a change of immigration status, it's not going to help us in helping this man. So this man came to us with some concerns. Immigration status does not change anything in our care of providing this patient. School performance, if this man was experiencing speech difficulties, if this man had problems in learning abilities, then we would think about whether he had some difficulties as a child in the school. Then this collateral history will matter. Truth of what he is saying. So when a person comes to you and tells you about the concern that somebody is after him and they want to kill him because they think that this person is involved in the killing of another person, the truth of what he is saying would not be a good option. We need to have a broader aspect about why this man is having this concern. Could it be something to do with the mental health? Family history of mood disorder is a good option, but it's just related to mood disorder. It doesn't cover the anxiety disorder. It doesn't cover the psychosis disorder. So I think childhood psychiatric disorder is a good option to select over here, that it could be something related to any PTSD he experienced. It could be related to something like anxiety disorder manifesting itself in these concerns, or he's just having stress because of what he thinks is like a delusion disorder as well. So it's very important when somebody comes to you with the concerns that somebody is after them and they're about to kill him. So always rule out if there is any delusional thoughts behind it, number one, and also to rule out any anxiety disorder, psychosis disorder, and mood disorders. That's what I think is best to check in the collateral history. We will take the whole psychiatry history of this patient. We'll talk about mood, sleep, energy, concentration, cognition, judgment, hallucinations, delusions. We'll talk about any substance use, any previous or past medical history of psychiatric illness or family history of such as well. Is it clear, guys? So I think it's best if we talk about the mental health aspect of this patient. Next question. Old patient, age is not given, smoker, that's a risk factor, is coming to you with the painless hematuria, very important. What do you want to do next in the set of investigation? CT scan of his abdomen, urodynamic study, or ultrasound? Painless hematuria in an old patient who is a smoker is a risk factor. We need to rule out either patient is having BPH or the patient is having a tumor. So first of all, what do we do? Start with initially in a painless hematuria, what do we start with? The initial investigation. What is the initial investigation for? Very good, Dr. Poona. We start with urine microscopic study, culture and examination. And then we go towards the ultrasound, or we go towards the CT-IVP. CT-IVP is intravenous pyelogram. If that is not available, you can also do ultrasonography. It's a good modality for the urinary pathologies. Urodynamic studies, it confuses some people, but always remember the urodynamic studies is used majority of the time to diagnose urinary incontinence problems. So if you're having frequency, urgency, incontinence of urine, then urodynamic study will help you to diagnose whether it's stress or what's the other one? It's stress incontinence, or it's or hyperstimulation incontinence. I don't remember the other one. But yeah, urodynamic studies is about emptying of the bladder studies, the dynamic pathway of the urine traveling from the renal pelvis into the ureter and into the bladder. Thank you, Dr. Fatma. Urge incontinence. So urodynamic studies is mostly done for that. It's not going to help in painless hematuria unless you're thinking maybe patient is having BPH or a prostate tumor and is causing incontinent symptoms. Then yes, absolutely go for the urodynamic studies. But if you're going to find the cause of the painless hematuria, imaging modality is usually required. If you have a look at this flowchart, guys, this is from RECGP. So if a patient comes to you in a GP practice and they have risk factors, they're elderly, and they're complaining of painless hematuria, the first thing you always do, even in painful hematuria as well, you always start with urine microscopy and culture, because painless plus painful hematuria, most common cause is a UTI. So if it is positive, you treat the infection, but if it is negative, you go for the modalities of imaging. The most important one is CT-IVP. It gives us a lot of information about the structures, but if you're in a regional area where you don't have that facility, you can always do ultrasound as well. Then you do urine cytology as well. And once any of the imaging modalities is positive, you refer the patient to the specialist. So CT, if shows that it's most of the time the ureteric stones are not painless, they are painful. Excuse me. But if they are renal stones, if they are higher up in the renal calyces, most of the time could be painless, but if they are in renal pelvis, they are painful stones. So if the urologist see there are stones in the urinary tract, they will manage it according to the location and the size of that stone. Other thing that we always look for in elderly people with the risk factors is urothelial malignancies. So prostate, bladder malignancies are very, very common, and require referral to the urologist, who will then do cystoscopy to diagnose and take a biopsy and then stage the whole thing. If it's a benign condition like BPH, again, we refer to the urologist, who might start the patient on medications like alpha antagonist to reduce the size, or they will do surgery to remove it or reduce the size of the prostate, depending upon the degree of BPH and the effect of the BPH on the patient's life. You can also study. I have given the links over here as well. I need to give it in a separate. You can paste. Okay. Otherwise, it won't open, I know. Okay. Clear, guys? Any questions? Alrighty. Next question. You have an elderly patient who is being managed for some condition in the ward. If urine analysis is an option. Urine analysis is a broad term. I do believe it covers urine MCS and cytology as well. So pick that as an initial option. Yes. But if they have mentioned urine MCS separately and urine analysis separately. I still think because it's written in our RACGP guideline that you do urine MCS first, go for urine MCS, please. Urine analysis is a very broad term. It includes every study of the urine, from microscopy, culture to cytology. It includes everything. All right. Elderly patient is being managed for some condition in the ward. She has some medical comorbidities and taking medication for them. While on the ward, she becomes agitated and is scolding the nurse. So she is just being verbal. Then she has vomiting and constipation. What is the next most appropriate action? Do a CT brain, see her serum calcium, or treat her constipation. So elderly patient is being managed for some condition in the ward and has some comorbidities and is taking medications for it. She becomes agitated and is scolding the nurse. So there's abrupt change in behavior. She has vomiting and constipation. So what is the next most appropriate action? CT brain, serum calcium, or treat constipation. I think it's a very we are going to look for the causes of delirium, right? And delirium in the elderly, very common, especially if they are in the medical ward being managed for various condition. Oh, let me show you guys one thing before. It is very confusing. I agree with you. So number one, guys, information is lacking in this question. So if they said like patient is febrile and then became agitated, then we will do like a whole sepsis screening on them, right? Which is same to the delirium screening. But she has been already managed for some condition. We don't know what that condition is, and she has medical comorbidities. They haven't mentioned which medication she is taking. Delirium can most likely be caused by some medication interaction, especially in the elderly population. Now they have given you there's a change in behavior and she has vomiting and constipation. Now, we don't know this vomiting developed suddenly or not, and if this constipation is long standing or not. If she has sudden vomiting and constipation, I would do the blood test first and also do a CT brain as well. All right. And then treat the constipation. But if she had vomiting and constipation, so my concern would be why she is vomiting. Maybe she had some fecal impaction that is causing. I would also do a CT abdomen and pelvis as well. So this is very confusing question. I agree with you. Now let's take it apart a bit. So she suddenly changed behavior as vomiting and constipation. In the elderly, we need to know about the medication. If she is on blood thinners or she had taken a fall, then I would initially start with CT brain. If they haven't mentioned anything like that, I would start with serum calcium blood test just to make sure there is no change in her electrolytes and then treat her constipation. Long-standing constipation causes delirium. Sudden constipation does not cause delirium. So I think the most appropriate option to choose among these would be to just start with the blood tests first. And if they have mentioned that she's on blood thinners, have some like myocardial infarction like condition, if they mention something like that, do a CT scan of the brain first, because we want to rule out any stroke feature or any brain bleeding in the brain. So this temp is very, very, very unclear. Next, most appropriate, if she has vomiting and constipation, I do believe, doctors, I do believe most likely because sudden change in behavior, I would like to do a CT brain first. I think I would go with CT brain first. What is very concerning right now is she has vomiting and she is agitated. I'm thinking maybe she has high serum calcium. That is why she is having behavioral changes as well. So serum calcium hypercalcemia can cause these symptoms. So we need to know about what her medical comorbidities are and what medication she has. That will change the answer. But if even if it's given like this, if she has acute agitation, she has vomiting with that acute agitation, do a CT scan of the brain. Initially, again, do this next most appropriate action, CT scan of the brain and bloods. I would go for CT brain first if it's an elderly patient who had acute change in the behavior and vomiting associated. So I would be very concerned if she might be developing some brain pathology like stroke or a bleed. So I think CT brain is the most appropriate here. If they hadn't mentioned about, if they say everything is fine, she is just a bit, she is just having vomiting and constipation, not agitation, then I would go with serum calcium. Yes, I do believe we should do a CT brain first. Acute agitation in an elderly population with vomiting, I would do a CT brain first. Serum calcium has to be high for a good amount of time to cause vomiting, constipation, and agitation. So I would do a CT brain first as a delirium screening. Let's have a look over here. I do agree with you, but here I think this most appropriate would be to rule out any brain pathology. Oh, why it's not putting it here? Your answer would, I do believe this. In case the patient has chronic constipation, what do we choose? In case the patient has chronic constipation, try if she is having acute vomiting and agitation, then do CT abdomen first. Maybe she is developing fecal infarction. Sorry, guys, I'm just trying to find this. The link I have given here is not opening. I'm just trying to find it here. There we are. When will we choose option C? If you think there is nothing wrong with the patient and just chronic constipation, choose option C. Mhm. Can't find this link, it's not opening. All right, guys, this link is not opening. I'll provide the link with the appropriate information for you, but this link is not opening at all. I'll make a note to myself that I need to provide the link. All right. Next question. 6-year-old child has come with croup. And he was admitted, is improving. A day before discharge, he suddenly develops stridor, has chest retractions, fever of 39 degrees centigrade. Chest auscultation shows that the breath sounds are reduced and there is tracheal tug. The child looks ill. What could be the cause for his condition? Number 1, epiglottitis. Number 2, bacterial tracheitis. Number 3, bacterial pneumonia. Number 4, pneumothorax. Or number 5, RSV. So patient was admitted with croup, pertussis infection. So, and was improving. Now, before discharge, he's having stridor. Chest retractions, fever, chest auscultation shows there is decreased breath sounds and tracheal tug. Child looks ill. What can be the cause? Now, majority of you are selecting bacterial pneumonia. Can bacterial pneumonia cause stridor? Anyone? Can bacterial pneumonia cause stridor? What is stridor? Can anyone tell me? Stridor is upper respiratory tract obstruction sounds, right? When you feel that the bronchioles and bronchi are obstructed, you will feel wheeze coming from the chest. But if there is like tracheal obstruction or obstruction of the epiglottitis, you will get stridors. So this is not bacterial pneumonia. This is not pneumothorax. So very high grade fever, and child is looking very ill, and it's a sudden change. So less likely to be caused by viral. Now, epiglottitis and bacterial tracheitis. Can anyone tell me how we can differentiate between the two? Very good. So epiglottitis will have posturing and drooling because it's the closure of your throat, basically. So trachea is a bit lower than the epiglottis. So looking ill, a posture, tripod posture, stridor, drooling of saliva. These are all the signs and symptoms of epiglottitis. And the child, again, is very sick. So this is most likely bacterial tracheitis, which is a very common complication of croup. Let's have a read over here. All right. Are you guys able to see the screen? So South Australian Pediatric Clinical Guidelines. How do we diagnose how a patient has croup? There is a very typical history. It's in school-going age children, most common under 5 as well, but 5 to 12 years of age. Patient has coughing fits followed by vomiting. It's a barking cough, and it's an infection of the upper respiratory tract, so there will be hoarseness of voice as well. What is the other name of croup? Can anyone tell me? There is a big name of croup. Laryngeotracheobronchitis. Very good, Dr. Sam. So there is degrees and severities of it as well. So when there is upper respiratory tract obstruction, you can't hear the sounds on the chest. Mild will mean that there is no stridor, and you can give oral dexamethasone or prednisolone to the patient and discharge home with the safety net advice about when to present to the hospital. Moderate is that when the child has stridor at birth, I have seen only one croup patient in my life, and the sounds their throat makes you scared to auscultate them. So you can literally hear it like a foot away when they're breathing. Their breathing sounds are so harsh, the stridor is so harsh, you can hear them straight away. So, and it's a good thing because if the stridor doesn't become audible to the parents, they don't bring the child to the hospital. So if it's a moderate, they will hear the child having a stridor at rest, and oral prednisolone stat dose, they improve within the next 2 hours or so. But if they are not improving and the stridor doesn't improve and they're dropping their saturations, we need to admit them and start them on nebulization with adrenaline. So this is the only condition where we don't nebulize with Ventolin because it's not going to help. Your oxygen is going to help, nebulization with adrenaline is going to help, and steroids are going to help. Dose of the pred is always in the children 1 milligram per kg per dose daily. Maximum dose day is 2 days, and adrenaline is 1 in 1,000 that you can give to the patient through a nebulizer. And it can be repeated multiple times. Alternative diagnosis, if it's less than 6 months, consider bronchiolitis to be more appropriate, and more than 6 years, consider another one. Longer duration of stridor, history of prolonged intubation, look for other causes. Toxic looking and excessive drooling. Now you should be thinking about epiglottitis, and that requires you to give the patient antibiotics. Asymmetrical chest signs and history of upper airway anomalies. It's usually viral. Croup is usually viral. It can be non-infective, usually 6 months to 3 years of age. And what else? It's the same. Croup and epiglottitis children should not be moved with, because they go into that posture to make them comfortable breathing. Steroids are the cornerstone of management, and nebulized adrenaline should be given in severe croup. Parainfluenza virus, the most common, yes, I forgot about this. Parainfluenza virus type 1 and 3, RSV, human metapneumovirus. We are having currently in Southeast Queensland, there is a sort of a epidemic of human metapneumovirus in the children and in the elderly population. So they are coming with like pneumonia, upper respiratory tract infections, and when we swab them, they're positive for human metapneumovirus and adenoviruses as well. Very common. Influenza is also common, and influenza is seasonal. So in winters, very, very common. RSV goes throughout the year. Parainfluenza virus also go throughout the year, but influenza is more in winter times. Now, what else? Okay. Main differential diagnosis for your group should be, again, acute epiglottitis. So posturing and drooling would differentiate. Bacterial tracheitis, number 2. Peritonsillar abscess. Peritonsillar abscess and acute epiglottitis, very difficult to differentiate because that will also cause drooling, but the child will have very high grade fever. It's also high grade in acute epiglottitis, but because of the abscess formation, it's much more worse, and septic child. It's a septic child. Retropharyngeal abscess, again, obstruction to the upper airway. Foreign body aspiration and anaphylaxis. Okay. So acute epiglottitis and bacterial tracheitis are potentially fatal if we miss them. We know that acute epiglottitis is because of Haemophilus influenza, and because of the vaccination, it's very, very rare now, but the child is very unwell and toxic looking. Primary course of management in the acute and bacterial tracheitis are to secure the airway and administer antibodies as soon as possible. Sorry, antibiotics. Airway management and examination should be performed by a multidisciplinary team, especially pediatric intubation skilled seniors should be present, because if we manipulate the child, their airway gets obstructed. So we need to secure them before manipulating that. Peritonsillar abscess always presents with fever. Again, drooling, change in voice, hot potato voice is there, and there will be neck extension and painful neck movements. Especially in the retropharyngeal abscess, swallowing difficulties will be present in peritonsillar abscess neck, because it's most of the time unilateral, but if it's bilateral, the neck can't move at all. You will feel like the kid is having mumps. Foreign body aspiration will also, it's one of the common differentials of a stridor. So sudden onset of a cough and a stridor in a well child without fever, always think about it's the foreign body. Anaphylaxis, again, well-looking child, sudden onset of angioedema, urticaria, low blood pressure, tachycardia, diarrhea, syncope, always think about anaphylaxis or what they have eaten in that time. Okay, for croup, we just take a nasopharyngeal swab. X-ray are not required unless you're thinking there is the other differential diagnosis that you really need to rule out. Steroids, we have talked about. Again, moderate to severe croup, always admit the patient to the hospital. Alrighty. Clear, guys? Any question? Yes. Because croup is viral infection, right? But if the child is already immunocompromised, they get bacterial, especially children, they get secondary bacterial infection like anything. All right. Clear, guys? Any question? Most common, Dr. Anjali, it's the parainfluenza type 1 and 3, not RSV. RSV is second number for croup. 25-year-old pregnant female was on a plane and she presented with left leg pain and shortness of breath. Vitals are, her blood pressure is 120/83, her pulse is okay, temperature is a bit high, chest auscultation is unremarkable, left leg swelling, and there's also redness. What is the initial step you would like to take? Do a VQ scan, D-dimer, CTPA, left leg Doppler, or a X-ray of the chest? Very good. So we will do a Doppler first of all to rule out a DVT. And if it is positive, start the patient on. What do we start the patient on? Therapeutic Clexane. We start the patient on therapeutic Clexane. Low molecular weight heparin. Very, very good, guys. Okay. All right. Why do you want to do chest X-ray when there is a clear indication that this might be a left leg, DVT? She's pregnant, number one, risk factor. Number two, she was on a plane. She's presenting with unilateral left leg pain and shortness of breath. We don't want to do a CTPA on a female. You can easily rule out if the DVT is positive on Doppler, is there any change in the treatment for PE? She might have PE. Where is the other one? Why not VQ scan? Because I would still do a left leg Doppler instead of VQ scan. VQ scan is not available in everywhere. Doppler ultrasonography is recommended. This one, no. Initially, yeah, I would definitely do the Doppler, not VQ scan. Where is this? There is ultrasound scan in the option. Left leg Doppler is ultrasound. Where is it? But the management will be the same, Dr. Fatma. So left leg Doppler will give you an answer whether there is a clot in the leg. And then even though there is a clot in her chest, management will not change. Where is it? It's not giving me the clear answer in this. All right. This is it. If you have a read over here, deep venous thrombosis. Up to 90% of the DVT in pregnant women occur in left leg, and over 70% are iliofemoral in their location. Iliofemoral DVT most likely to embolize than a calf thrombosis. Sign and symptoms: leg pain, discomfort in the absence of trauma, swelling, tenderness, or increased temperature with the edema of the limb. Lower abdominal pain may be present if there is pelvis or groin thrombus. Homan sign, which is very, very important, but it's unreliable because it can dislodge the DVT. So Homan sign is when you dorsiflex the calf, it causes pain. So it can be present in the DVT in females. Your history taking should also include symptoms of the PE. So if you're asking about unilateral pain, always ask about chest pain, tachycardia, the symptoms our patient is having. Investigation: complex duplex ultrasound. When iliac vein thrombosis is suspected, you should also consider duplex Doppler ultrasonography. D-dimer is unreliable in pregnancy. It should not be done to exclude a VTE, especially in high-risk women. So pulmonary embolism can happen in the patients. DVT usually perceives pulmonary embolism, but the thrombosis may be asymptomatic until the embolization occurs. Venous symptoms: dyspnea with or without reduced oxygen saturation on pulse oximetry, chest pain, collapse with hypotension, hemoptysis, faintness, tachycardia or arrhythmia, raised jugular venous pressure symptoms and sign associated with DVT in peripheries. You can do ABGs, complete blood count, electrolyte, liver function test, coagulation screen, especially a prolonged APT should raise suspicion of the lupus anticoagulation. Consultant opinion to be sought before proceeding for a VQ scan or a CTPA. Advise that VQ scan carries slightly increased risk of childhood cancer as compared to CTPA, and ensure that woman knows about the investigation if you're performing it. If there's evidence of the circulatory collapse, you should always do a ECG or cardiac enzyme and urgent echocardiography. So if a woman is presenting with left leg pain and shortness of breath, please do a Doppler first before organizing a CTPA, because your Doppler will prevent you from doing CTPA. Once you have diagnosed that the patient has DVT, start the patient on the management of it, which is low molecular weight heparin. It's the same for PE and DVT, same duration of time, same dose as well. So don't go looking. If a pregnant female was presenting with just shortness of breath, chest pain after a flight, go for a CTPA. Don't do a leg Doppler. But if she is presenting with left leg pain, that will prevent you from exposing a pregnant female to radiation by doing a CTPA. VQ, always VQ. In pregnancy, VQ scan. It's not available everywhere. So there was a question last year that a pregnant female comes to the secondary or regional hospital who does not have, they have clearly mentioned who does not have imaging modality other than X-ray and CTPA. And they just presented with the symptoms like chest pain, shortness of breath after a prolonged flight. So they gave VQ option, D-dimer CTPA, X-ray. So in that scenario, select CTPA because they mentioned that they don't have any other imaging modalities other than a CT scan or a X-ray facility. Then your answer will change. Have a look at this as well, guys. Suspected pulmonary embolism in the pregnant females. Chest radiograph suspected. D-dimer is not done in pregnant females. Bilateral lower limb Doppler ultrasound positive, treat for P. This was the old guideline. That's why I showed you guys the essay. Don't follow this one. Please, those who have studied this one, this was in October 2013. Don't follow this guideline. This is Western Australian guideline, but the one I have discussed with you, SA Health one, it is the most updated one. This is 2013 one. Don't study this, please. Clear, guys? All right. Next question. Because sometimes when you search in Google, there all of the guidelines which were, or any resources, they pop up. If there is history of chest pain and shortness of breath, and it's a pregnant female, please do an ECG first. Always do an ECG first. Does not matter pregnant or not. Even if you suspect it's a PE, always do an ECG on the background of chest pain. We don't want to miss any ACS event in a patient. Can happen in the pregnant patient as well. So please always do ECG initially if only shortness of breath and chest pain. This chart, don't study this chart. I didn't show you guys to, I just showed you, don't study this. Cross. No, don't study this. This is an old one. Okay. Where's my pen? All right, got it. A lady to be switched near delivery. If pleuritic chest pain is written, still ECG first. Pleuritic chest pain, yes, please. I would still do a ECG. Chest pain, pleuritic or not. A lady came to complain about her treatment in previous visit to same hospital. She was restrained and she was assaulted. What to do next? Complete incident report. Tell her complain through the proper channel. Tell her it was done on her benefit. Tell her recollection of the event is incorrect. So if anyone comes to the hospital and they want to complain about the services they have received, then we always ask them to go to the administration office. There is a office called what's it called? Patient Communication Services Office. There is an office administrative department in every hospital that deals with this. So if a patient comes to you and they said, oh, I have been here so and I have received so and so kind of treatment, just ask them to go to the administration area, and the reception will guide them about where to make the complaint. And it's done more than you think. Like, this happens a lot. Okay. Next question. Incident report is when you make a mistake. For example, if I have ordered a wrong dose on a patient and that has been administered to that patient, then we do an incident report. So anything which was like an error made on our part of giving care to the patient requires that incident to be reported. So you'll do a whole incident report. It can be done by the doctor himself. It can be done by the nursing staff. And then you have to explain to the patient as well about the error you have made. Okay. Next question. 34-year-old lady complaining of fatigue, becomes tired easily after walking short distance, difficulty combing hair. Father died of stroke. Mother has diabetes. She has tachycardia. There is awkward drop in her chair when she is asked to sit. There is decreased shoulder muscle mass as well. What could be the cause? Cerebellar dysfunction, neuromuscular junction disorder, or thyroid disease? Okay. We all agree this is not cerebellar dysfunction, right? Okay, let's read a few things and then. So sign of cerebellar disorders, we know there is gait problems always, so ataxia will be there. And in a cerebellar disorder, there will be wide-based gait. So if there is loss of one side, so the other side will try to compensate. So there is a wide-based gait. There will be incoordination of the fine coordinated movements, like dysdiadochokinesia, finger nose test will be positive. Yes, I can enlarge. Sorry about that. Let me just increase this in size. Pixels. And then we know that cerebellum is also involved in articulation. So there will be dysarthria. Dysdiadochokinesia, we have already discussed about. Dysmetria is same as dysdiadochokinesia. Hypotonia can be there. Most of the time, nystagmus is there, and tremors are there. What about thyroid disease? So if we are thinking that it could be because of the thyroid problem, I agree with you, happens a lot. So what kind of problems do muscles happen in the thyroid? Fatigue can happen in hypothyroidism, depression, memory is impaired concentration, mental fog, and there is sometimes hypotonia. but that is like a generalized hypotonia. There is not a particular set of muscles that are affected. Whereas in hyperthyroidism, you will be a jittery mass. I always used to remember hypothyroidism, people are jittery mass. So they're very thin, they are anxious, nervous, irritable, and they have tremors, lots and lots of tremors. And they can have tachycardia. So this person has tachycardia and hypotonia. So does not fit with the, it's like a mixed picture of the thyroid disease. It does not fit one thyroid disease. Most likely this patient has neuromuscular junction disorder, which is, can anyone tell me the name of the disease here? Myasthenia gravis. Very good. So fatigue, becomes tired easily after walking, which is one of the features of the myasthenia gravis. Tiredness at the end of the day. Upper proximal muscles are affected, like difficulty combing hairs. Tachycardia could be a feature. Awkward drop into a chair when asked to sit is also very common in the myasthenia gravis. So it's more likely a neuromuscular junction disorder. Sorry about that. What is myasthenia gravis? It's a neuromuscular junction disorder in which anti-acetylcholinesterase antibodies are there, and it doesn't cause the action potential to go across the neuromuscular junction. Oh, I have to link in. Let me just. It's a very good journal to read about this. Sometimes when I'm not logged in, this wouldn't let me access the journal. My links are not opening today for some reason. Do you guys have problems sometimes with opening up the links? Okay. It's a muscular disorder, especially those. So this patient is having two symptoms, one from hyperthyroid, one from hypothyroid. Hypotonia or weakness of the muscles happen mostly in hypothyroidism, and she has tachycardia as well. So it doesn't fit a thyroid disorder. All right, myasthenia gravis is when the voluntary muscles become weak and get tired easily, especially at the end of the day or after exercise. Very common in females younger than 40 and males more than 60. And then your weakness will be head to toe going, like an ascending paralysis. So symptoms can come from your eyelids, vision, speaking, chewing, swallowing, especially muscles of the shoulder and the pelvis muscle. So it gets worse when the affected muscle is used. So you can have drooping of the eyelid, speech difficulty, swallowing, chewing, facial muscle weakness, Neck and arms and legs, very, very common, and also affects when you walk, when to see a doctor before you become totally paralyzed. What investigation would we usually do for myasthenia gravis? Can anyone tell me, guys? What do we do as an investigation for diagnosis of myasthenia gravis? This is how they look like. Very good. We do the antibodies, and then we do the EMG and the nerve conduction studies as well. Very good. What else? EMG, blood test, we check for the acetylcholinesterase antibodies, or you can musculoskeletal antibodies is the same one. How do we treat it? We give the patient pyridostigmine, that is the first drug of choice. Thymectomy is done in few patients, especially in the children who are coming with myasthenia gravis symptoms. Complement inhibition is not approved in Australia to be done. Immunosuppressive drugs can be given. Plasmapheresis and IVIG is usually done in Australia. So plasmapheresis and pyridostigmine and thymectomy. Yes, initially we do acetylcholinesterase antibodies and then EMGs. Because EMG tells you about the pattern of weakness a muscle is having. So every disease that affects the peripheral muscles, like a neuropathy, that can be diagnosed with EMGs and NCS. Both are the same things. Alrighty. All right, guys, it's 9:30. Let's take a break of 10 minutes. Proximal myopathy can occur in hyperthyroidism, but again, it's usually the lower limb which is affected. And let me just show you guys where it is. Type of proximal. Where is my, okay. Do you guys remember what is the peripheral neuropathy called? There's a specific name for the neuropathy in the hyperthyroidism. Management, we start with pyridostigmine, which is the anticholinesterase inhibitors. And we also do thymectomy and IVIGs and plasmapheresis. Okay, Dr. Who was somebody was asking me, Dr. Mehra, this is how proximal myopathy looks like in the peripheral myopathy in the thyroid disease looks like. Muscle weakness, myalgias, wasting of pelvic and shoulder muscles, fatigue, heat tolerance. They are mostly associated with rhabdomyolysis, damage to the muscles that control eye, and temporary but severe attacks of muscle weakness that are associated with low potassium levels. So they cause transient paralysis. Treatment involves restoring the thyroid hormone and may include thyroid drugs, radioactive iodine, and some partial or complete surgical removal of the thyroid. Muscle weakness improves with it. Is it clear now? So it's the peripheral myopathy in the hypothyroidism is different to that occurs in the myasthenia gravis. The fatigue at the end of the day is pathognomonic for myasthenia gravis, especially if you use the skeletal muscles. That fits our scenario. Alrighty. Let's take a break, guys. 10 minutes break, and then we can come. We have how many slides to go? We have a lot of slides to go, so we'll quickly go through them and finish our class today, okay? So 10 minutes break, and then we'll be back.
Hello.
All right, guys, welcome back. Let's start again. John, who's a 50-year-old man, has been having some trouble swallowing solids for the past few weeks. He also noticed occasional regurgitation of undigested food. He decided to consult doctor to figure out the underlying cause. What is the investigation you would organize to diagnose him with? Esophagoscopy, barium meal follow through, barium enema, or manometry? Barium meal follow through. Majority of you are opting for that. Do you know what barium meal follow through means? It means that the barium goes all the way to the large colon to your anus, and then you take films of that area. Barium enema, it's from the back passage. So this patient is a 50-year-old man who is having dysphagia for solid foods and occasional regurgitation. And he came to the GP. What do you want to do as a GP first? Have a look over here. Key steps for assessing symptoms of dysphagia. Patient presents with symptoms of dysphagia. You take a history and then you try to find out whether it's oropharyngeal dysphagia or esophageal dysphagia or a globus dysphagia. So esophageal dysphagia will have, like, you have initiation of symptoms within seconds of swallowing. There is regurgitation of undigested food, discomfort in retrosternal area, whereas oropharyngeal has association with initiation of swallowing. There is aspiration and cough, and repeated swallowing to dislodge the food in your throat. These are the symptoms of oropharyngeal. Globus will have mixed features. So either of the dysphagias, you identify the type of food that you're having difficulty with. Structured causes will cause solid food dysphagia, whereas motility disorder will cause liquids and solid food dysphagia. So you need to identify the frequency and persistency of the symptoms. If it's intermittent symptoms, then you think about in structural causes like web eosinophilic esophagitis, and in oropharyngeal, you suspect Zenkel's diverticulum or cricopharyngeal web. If you suspect it's a progressive one, then you think about stricture or cancer or tumor. If you think about motility, intermittent, then spasm and stroke or neuromuscular disorder, neurodegenerative condition. If you think about progressive, then stricture, cancer, neuromuscular disorder, and neurodegenerative condition like achalasia. Now, what our patient is having is a 50-year-old who's coming with dysphagia and regurgitation. So that's most likely esophagus one. So in esophagus one, do we organize barium swallow, or and he's having structural deformities? For structural deformities, what do we do then? For esophageal structural deformities causing dysphagia, we just organize esophagoscopy for the patients. Is it clear, guys? Yes, manometry when you suspect achalasia. When do we do B? Let me just find out for you. Barium enema is done for when you're finding out if there's a intussusception in the kids, but then we do. No, regurgitation of undigested food doesn't always mean Zenker. And in Zenkers, we don't have solid food troubles. We have regurgitation, halitosis, and trouble to liquids and solid with a bit of drooling sometimes as well. 50-year-old man having trouble swallowing solid foods for the past few weeks. Notice occasional regurgitation on undigested food. What are you thinking about? It's not pharyngeal pouch. No, I don't think so. It's Zenker's diverticulum. Let me show you guys. Zenker's can happen in old and young people, but in Zenker's, there can be like a neurodegenerative disease, or there's a pouch formation at the back of the throat. Okay, have a look over here, guys. Yes, but to solid foods. And if it's a Zenker's diverticulum, the swallowing food should be initial swallowing problems, right? That's why we do swallow assessment for Zenker's diverticulum, especially if you're thinking of Zenker's diverticulum. And usually in the oropharyngeal one, if it's, what are the causes of the oropharyngeal? If you're thinking about Zenker's diverticulum, then yes, we do a swallow assessment, like a video endoscopic swallow study, or we can do barium swallow. I'm thinking it's either a stricture or a tumor because of the age and solid food. So if it's a solid food dysphagia, always do esophagoscopy. Clear, guys? When you think about, like over here, your differential diagnosis, then in esophagus, it could be Webb. In oropharyngeal, it can be Zenker's, but with Zenker, always remember there will be initiation problem, drooling, halitosis, then undigested food. Not necessarily weight loss should be there, could be stricture as well. Clear, guys? Progressive dysphagia to first solid, then liquids, pathogenomic for structural causes. In elderly, always rule out cancer. If they are given like constant requirement, if it was given both solids and liquids, then yes, I would absolutely think about Zenker's. It's just solid food. Then that's why I'm thinking of could be like a structural cause. In structural causes of oropharyngeal, B is done. There, guys. So next question, on reviewing a pregnant female of 14 weeks, she said she had pertussis vaccine 8 years ago. So when will you organize the next one? I think we have done this before as well. Very good. We will organize at 21 weeks. Good. With pertussis, what else is given? DPT. Very good. So we give DPT at 20 to 32 weeks of pregnancy. And who should also receive the pertussis vaccination? Just the mom, or both the mom and the dad, or whoever is going to be taking care of the baby should be having a booster? Very good. All right. Next question. Patient with painful left axillary lump of 1 centimeter. Recently, after how many years booster is required? That's a good question. Let's have a look. I don't remember, guys, so I have to see. I just remembered the initial doses. All right, so we usually give 2, 4, 6, 18, 4 years, and then 11 to 13 years. And recommended then at 50 to 65 years. And pregnant women should be given between 20 to 32 years. And in healthcare workers, it is recommended every 10 yearly for them to have it. I'm just going to put this over here so you guys remember. Whoops. There you go. So 2, 4, 6, 18, 4 years, which is the normal EPI schedule. 11 to 13, you receive 1, 2, 3, 4, 5th booster. And then 50 to 65 years of age are recommended. Pregnant female 20, 32 weeks, and healthcare workers every 10 years. All right. Our question again. So patient presenting with a painful left axillary lump of 1 centimeter, recently had COVID vaccination with the mild swelling and erythema of the left arm, had history of breast cancer on the right side 10 years ago, otherwise normal findings. So what is the diagnosis? Very good. Reactive lymphadenitis. So what is the difference between hidradenitis suppurativa and reactive lymphadenitis? We know it's not metastatic deposit in lymphoma. Yes. Hidradenitis is like abscesses in every hair follicle, whereas is reactive lymphadenitis, there's just swelling. I have recently seen this case. She presented with labial abscess, but also had bilateral axillary abscesses in multiple areas and multiple abscesses in the groin areas as well. So the labial abscess was very large, kind of like Bartholin cyst, but different location. And it's very true that every hair follicle in her body was prone to formation of an abscess. She has been on yes, it happens very often. These patients, hidradenitis suppurativa, they are very prone to becoming MRSA. So my patient was on clithromycin when she presented with the GP, 750 milligram dose. All COVID vaccinations might cause reactive lymphadenopathy, and this case can serve as a supplement to observe side effect studies. Pfizer is uncommon, but this is the most common vaccination among the AstraZeneca Pfizer vaccination that can cause 10 years ago, less likely to have reoccurrence on the left side, likely to reoccur on the right side. Erythema, mild swelling, the metastatic deposit does not present with that unless it's infected. It presents with a new lump. Painless lump. Unless it's infected, painless lump. Reactive lymphadenitis, you don't need to do anything. Pain relief, rest, icing, that sort of thing. Just symptomatic management. It goes away with the resolution of either viral illness that is causing that, or within the COVID vaccination, it goes away in 2 weeks. Next question, guys. Old man with wife, disoriented, confused. He has diarrhea for 24 hours, history of proctectomy. 1 week ago, catheterized for it. IV fluids given yesterday and conscious level improved. Now he comes with urine output of 20 mils per hour and his RFTs are normal. What do you want to do next? Give bolus of IV normal saline, IV furosemide, encourage oral rehydration, or flush out the catheter. Very good. So whenever a patient presents with the catheter from home with a low urine output, always think that there might be a blockage. So always, whenever there is a low urine output, think about, and the patient is already catheterized, think about flushing the catheter first, number one. Number two, give the patient, normal urine output is 30 mils per hour, as per my knowledge. 30 mils per hour is normal. So you flush the catheter and then give fluid challenge to the patient. If the patient is orally rehydrating, encourage that. If the patient cannot drink for some reason like vomiting, unable to drink properly because disoriented, then give them IV normal saline bolus and observe the catheter urine output. If the patient is still having low urine output, then you need to organize the renal function test to see if there is any kidney injury going on there. His RFTs are normal, most likely is either a catheter problem or the patient is dehydrated. Flush out the catheter and rehydrate the patient and see if the urine output improves or not. There, guys. You guys can study this from here. All right, next question. Adult patient with features of meningitis. Gram stain shows positive diplococci. What is the most common causative organism? Neisseria, meningitis, streptococcal pneumoniae, Haemophilus influenza, or E. coli? So Diplococcus gram-positive among all of these is for the very good. It's Neisseria meningitis. Meningitis. All right. Oh, sorry. That's gram-negative. You guys are right. Not this one. Streptococcus pneumoniae. So gram staining, gram-positive diplococci are Streptococcus pneumoniae, Streptococcus, I don't know what this is, Enterococcus, and Lactococcus, and Neisseria is gram-negative. Always forget that. Gram-negative diplococci. Thank you for correcting me, guys. All right, next one. Young woman with sudden onset of blurry vision, numbness and tingling in her legs, stressed at school, worried about her mother's health. She had 2 episodes of urinary incontinence. MRI shows multifocal white matter hyperdense T2 lesion in corpus callosum and periventricular area. What is she likely developing? Dementia, depression, or psychosis? So these are early signs of dementia in this young lady. White matter lesions are commonly observed on MRI of scan in older adults and are thought to occur in the context of cardiovascular disease. These age-associated white matter lesions have been affiliated with cognitive decline, including dementia and also depression and impaired mobility. It also indicates that vascular disease is in progress in the brain. So this female might be having dementia or MS. I agree with Dr. Roshan, it's MS. All right, next question. Someone with bleeding from the rectum, not diagnosed. He had normal gastroscopy. Patient is resuscitated. He underwent sigmoidoscopy, but not clear as cavity filled with blood, and bleeding is continuous even after resuscitation. What is the next step to identify the bleeding? Multiple sclerosis. Capsule endoscopy, CT angio with cauterization, or rigid sigmoidoscopy. So we have discussed the scenarios like a bajillion times in different way. So if you are not able to identify a bleeding in the GI, even you have done endoscopy or gastroscopy or sigmoidoscopy, and the bleeding is not identified, and even by resuscitation, patient is still losing blood, you have to do a CT angiography to identify the bleeding and then cauterize that. Yes, hemodynamically unstable patient, you need to do CT angio. These are also available within the theater. So there are big U-shaped unstable patients. We don't do capsule endoscopy. There are big C-shaped CT angios which are available within the. Yeah, if unstable, don't go for endoscopy capsule. If stable, you can go for capsule endoscopy. So these are big C-shaped CTs, and the monitors are also there. So surgeons can inject into the dye and can see on the CT scan, which is done on the patient on the table, and then they can cauterize that artery. All right. Hemodynamic unstable angiography. Persistingly big, then you open up the patient. But most of the time, this process is very, very accurate. All right. 6-year-old child brought by foster care with complaints of imitating sexual activity with neighbor, planned to stop the placement. Child's mother was prostitute and child was brought to foster care because of the physical abuse. What is the immediate next step you would do? Refer to child psychiatry, notify the child protective services, placement to experienced carer, or counseling of the carer. So when you see something like that, this is a big red flag that we need to organize safety for the patient. So notify the Child Protective Services, please. You guys can study about sexual behavior in young children and guideline about what to do in a healthcare facility. Elderly patient was assaulted by care workers in the aged care. Elderly patient assaulted the care. Last question answer is Child Protective Services. Dr. Faria? So whenever a patient is brought and they are exhibiting the sexual behavior, especially young children, and they are placed in a foster care, there's a concern that there might be physical abuse in the foster care as well. So you call the Child Protective Services and make sure that the patient is in a safe environment before investigating the cause for it. Elderly patient assaulted the healthcare worker in the aged care facility. He did the same a few days ago to go to another worker. He is forgetting to take the medications and unable to take care of himself. What will you do next? Start donepezil or give him antidepressant? So this elderly patient is in an aged care facility under the care of care workers. So he's in a safe environment. We don't need to report this incident to the police. This man is clearly suffering from dementia. So what do we do to treat the dementia? You start them on dementia medications. Antidepressant is not going to do anything. He's not depressed. He is having cognitive decline with behavioral changes, which is dementia. That is very common because they forget the carers are not in the dementia patient. If there is any change in the environment, the elderly patients can assault the healthcare workers who are looking after them. This is very common. We don't call the police in there. We treat the cause or the dementia in that patient with anti-dementia medications. I would call the police if the elderly patient was having cognition. He's not having cognition. So this person is not at fault for assaulting the care workers. What they do is in the aged care facility, especially when there is some incidents like that, they try not to change the healthcare workers looking after a particular elderly population, because any change in a dementia patient's environment can trigger drastic behavioral changes towards a particular person who is looking after. It's very difficult. So they need to calm them down. They need to have daily reminders, a particular routine even. So these things are not reported unless the healthcare workers think that the patient had capacity and he assaulted knowingly that he is going to be he had the capacity and cognition to recognize what he has done, then definitely should be reported to the police. Otherwise, we don't. We just manage it. The GP gets involved, memory clinic, medications, environmental strategies, our routine. There are lots of things that are here in place for these vulnerable population. They're very vulnerable. All right, have a look over here about the role of donepezil. Donepezil reduces behavioral symptoms, mood disturbances and delusions in patients with relatively severe psychopathology in the dementia. So it's better if you start the patient on medication, get him There are aged care workers who are particularly trained to take care of these people. So a particular routine, management strategies, memory clinic with the GP, medications can help control the behavior as well. All right. Any question, guys? Yes, yes. Always rule out whether it is dementia or delirium. But because he's having forgetfulness, most likely dementia, but always ruled out if there's any organic cause going on that might cause a change in behavior. No worries. 18-year-old boy has had abdominal pain for the past 24 hours. He has been unwell for the last few weeks, lost 10 kilos, and has been taking a large bottle of water every night. Vitals, his temperature is almost normal, heart rate is 115, blood pressure is okay, respiratory rate is high. He is clammy, aggressive, and confused. What is the most likely diagnosis? Addison's crisis, diabetes insipidus, DKA, hyperaldosteronism, or syndrome of inappropriate ADH secretion. All right, go through this first. Feeling tired and sleepy, confusion, passing out, stomach pain, feeling of being sick, need to pee more often, blurred vision, being very thirsty, high blood sugar levels. We know this is DKA, right? What are diabetes insipidus symptoms? Hair loss, blurry vision, abdominal pain, decreased appetite, darkening of the skin, shaking or tremors, depression, dry eyes, weight loss, rapid heart rate, low blood pressure, muscle cramps, large amount of urine, fatigue. This is diabetes insipidus. All right. Headache, fatigue, excessive thirst, high blood pressure, low potassium, muscle cramp, anxiety, depression, memory loss, heart arrhythmia. What are the causes of this? What is this, guys? What is this? Excessive thirst with low potassium. Look at this one. Vomiting, low blood pressure, loss of consciousness, hyponatremia, changes his personality, confusion. This is syndrome of inappropriate ADH secretion. What is this? This is Addison's crisis or adrenal crisis. What do you think our patient is having? 18-year-old boy had abdominal pain for the past 24 hours, unwell for the last few weeks, lost 10 kg and has been taking a large bottle of water to bed every night. Vitals is there's a brewing temperature there, heart rate is high, blood pressure is okay, respiratory rate is high, clammy, aggressive, and confused. What is the most likely diagnosis? Most commonly, this might be a DKA. Clear, guys? So why I'm not thinking of be less likely to happen in an 18-year-old boy? I do agree symptoms are very similar to it, but abdominal pain, why abdominal pain happens in diabetes insipidus, let's find out. It is gastroparesis. Diabetes insipidus. Gastroparesis and constipation causes abdominal pain in diabetes insipidus. All right. Coming back to the question, why it's not Edison crisis? Because the blood pressure is not low enough. And if they have given us blood sugar levels, what would happen in blood sugar levels, guys? In Edison crisis, the blood sugar levels are not high. The blood sugar levels are low. Very good. And there is a lot of vomiting, and patient has a lot of muscle pain as well. Okay. Yes, it's dehydration by vomiting a lot, and patient has muscle cramps. There's a lot of muscle cramps. Okay, and lab investigations. So in hyperpigmentation obviously happens because of the adrenal gland insufficiency, but because Addison crisis, there will be no, there is lack of hormone. So your sodium, potassium, sodium will be low, potassium will be high or low, and cortisol levels you have to check. Next thing, hyperaldosteronism. It's the opposite of that. So instead of having low blood pressure, you will have high blood pressure. And instead of having high potassium levels, you will have low potassium levels. Syndrome of inappropriate ADS secretion, we know that there will be hyponatremia. So patient will present with confusion more, fatigue. When he starts having convulsion, this was threatening or life-threatening signs. Is it clear, guys? So hyperaldosteronism and Addison crisis will be opposite to each other. Addison crisis will have low blood pressure, high potassium levels, cramps, vomiting, pigmentation, whereas hyperaldosteronism is hyperactivity of the adrenal gland, so more hormone is secreted, which will lead to high blood pressure and low potassium levels. Diabetes insipidus, patient will have similar features, but less common in 18-year-olds, and more hair loss, blurry vision, confusion, shakiness, more neurological symptoms. All right. Next question. I don't think so we'll be able to complete the class today, but we'll do another class to complete the rest of the question. Hemophilic patient is presenting with knee hemarthrosis. What to do first? Aspirate, factor VIII transfusion, or vasopressin. So hemarthrosis occurs in which patient? Can anyone tell me? Hemophilia, which A or B? Very good. So hemophilia A, which is factor VIII deficiency. Okay, so we'll do factor VIII transfusion. That was easy. Okay. 65-year-old lady came to GP clinic with vaginal irritation. There is mild redness with no discharge and bleeding. She also complains of dyspareunia. What is the treatment of choice? Topical estrogen cream, pessaries, biopsy for cancer, ultrasound of the uterus. So what is she having? Answer is absolutely right. She's having atrophic vaginitis. So there is no discharge, no bleeding, but is with irritation, mild redness, and pain during intercourse is common because of the dryness of the vagina. So this is vaginal atrophic vaginitis, and we give estrogen because these people don't have estrogen. Next question. I'm not going into detail about the guideline. You guys all know about the treatment. Patient is a refugee from Africa, came for early checkup. His eosinophils levels are raised and took albendazole 3 days before leaving Africa. That time, his malaria was negative. Now, what do you want to check as an initial refugee assessment? Malarial rapid antigen or stool for ovocytes, cystin parasites? Read again, guys. Refugee from Africa, eosinophilia is there. So what do we will test for? Very good. We'll test for stool for ova cystin parasite. Excellent. There is a very big book, this one, for immigrant health assessment. Have a look over here about what do we go through. Do you want me to have a look, or do you guys want to continue questions? Eosinophilia, parasites. Looking for parasites. We are looking for parasites, people. Okay, have a look. Refugees should have full assessment after arrival in Australia within a month of their arrival. And we test them for immunization status, tuberculosis, hepatitis, parasites, malaria, depending upon the origin, nutritional status and growth, development, disability, vision, hearing, mental health issues, trauma exposure, confirming child's birth date, and issues they have after arriving to Australia. So what are the things we do? Full blood examination with the peripheral film, ferritin, hepatitis B serology, strongyloid serology, tuberculosis screening, fecal specimen ova cystin parasite, if eosinophilia, OCP, and directed treatment. And then we can also do vitamin D, calcium phosphate, ALP, serum, vitamin B12 and folate, MMR and varicella serology, malaria screening, depending upon the origin, hepatitis C, A, HIV, STI, syphilis, and Helicobacter. So our patient was coming from Africa, but had full blood count already done, which shows eosinophilia. So that will make us more towards the parasitic infestation, even though he took albendazole, which is anti-parasitic medication. We will still test his stool for ova. There are 3 things: ova, cystin, parasite. Ova, cystin, parasite are the life cycle stages of infestation of parasite within the body. That's why we are testing all 3 for them. Is it clear now, guys? All right. Clear, guys? All right, so we'll stop here today because the time is finished. But we'll do the rest of 1, 2, 3, 4, 5, 6, 7, 8. 8 question in the next class. I hope you had a good session with us. Thank you so much and have a lovely evening, okay? And if you have any queries regarding any of the question, or if you disagree with any of the answers, please direct me your queries on the messenger, and I'll find some more literature to help with the answer. If I find some literature that support your answer, I will discuss in the class as well, okay? Thank you, everyone. Have a very good night.